Thank you, Peter, and welcome to everybody here from Ireland, southern north, and from abroad to within the EU and outside the EU, wherever you come from, you're very welcome. So just when I was a medical student many centuries ago, there was a number of maxims that were drilled into us from the word go, starting as a medical student. And one of the most important was primum non nocere, which translated as first and foremost, do no harm. And this was particularly important and remains important because once you accept that you should do no harm, all other decisions in medicine flow from that. And this maxim also served as an assurance to patients that we weren't just there to heal or to attempt to heal and to relieve suffering, but also that we wouldn't do any harm. And it formed the basis of the trust between doctors and patients, which is the bedrock of clinical medicine to this day and has been for many centuries. And despite all the things that happened, this trust remains very strong. Of course, the doctor-patient relationship has changed radically over the past few years. It's gone from being quite a paternalistic relationship to one based on partnership, where patients are seen as co-deciders in their healthcare, with a desire to get explanations and options, and of course be told when things go wrong. In a sense, the relationship is now a meeting of two experts, one who's got training and one who knows what is wrong and notices things and is able to provide that information and decide on what options are best. Now, over 20 years ago, the Harvard Medical Practice Study brought some rigour and standardisation to the whole idea of medical error. And this led to a seminal paper in 1999, 20 years ago this year, from the Institute of Medicine called To Err is Human, where using that Harvard classification, they estimated that between 40 and 70,000 people per year died in the United States as a consequence of medical harm. And this led to a comprehensive effort to identify, define and to reduce harm, which in a sense acted as a major springboard for the quality and safety movement that we see in our healthcare system today. And this, the story of Valproate is, of course, resonates strongly in this context because it's in the course of treating people, of trying to relieve suffering and to heal people, harm was done. And the scale and the impact of this harm evolved with more knowledge. And the knowledge, we could say, as doctors in a more paternalistic age, the knowledge came about due to better research. But it at least was also attributed, if not more so, to the persistence, vigilance and doggedness of patients and their families in noticing things that were going wrong and not accepting explanations that were given to them. And the lesson, if we didn't know already, was that if the medical profession don't want to do any harm, they must listen to patients. And this conference today is timely. It reviews the emerging evidence of valproate in pregnancy, and I'm proud of the work that we've done in collaboration with patients and patient representative organisations in improving communication with prescribers, with doctors, with pharmacists, to identify as many women as possible who are on valproate in order that we can reduce harm. And the communication exercise led out by Fidelma, who's here today, has involved, again, working in communication, in collaboration with all those groups, has been in contact with over 1,600 women who are on valproate. It has established a patient liaison service led by nurse specialists who provided advice to over 400 women. It's established a website, a social media campaign. It's provided counselling to women who've been identified through this communication exercise. And we've also appointed a dedicated consultant paediatrician to assess those patients who've been identified as potentially having this syndrome. We've also approved and are recruiting a consultant geneticist to provide as much support as possible to families and to women in this who've been identified. And in looking forward, rather than wait for something to happen as has happened with valproate, Colm Doherty brought a proposal to us to establish a women's health programme. We would appoint nurse specialists in each of the maternity networks so we could look at the whole scope of women who have epilepsy in pregnancy to identify any potential harm that may come in the future from people who are on drugs now that we think are safer, but time may prove otherwise. And part of the work of this programme is to establish a registry for patients with epilepsy in pregnancy. I'd like to acknowledge the partners in this journey, not least OACS Ireland, led by Karen Keeley and our colleagues, Epilepsy Ireland, Peter Murphy. And without their tenacity and unique blend of both patients and impatience, we wouldn't have got to where we are today. And I really think we owe them a huge debt of gratitude for getting to this stage in the journey. From the HSE, Professor Andrew Green, Colin Doherty, I mentioned Cora Flynn and her team of nurse specialists, Fidelma Brown, who's led out the communication, Deirdre McNamara, who's tirelessly worked to tie all this together, and from the moment we decided to embark on this project right up to the conference today, and to Sabrina Doyle as well from my office. It's been my privilege to meet the families who've been involved with this, and to see, and in the week of Laura Brennan's passing, it's a reminder to us again, those of us from the caring profession, that patients' input and experience not only makes our work easier, but reaches parts that we can't reach, no matter how good our training is and no matter how expert we think we are. I'd also like to thank the speakers who've come. My understanding, this is the first conference outlining a national plan in the EU, and for their benefit, I'll finish with an Irish proverb, Ní neart go cur le chéile, meaning we're stronger working together. Thank you for listening.